It's quite a long way from College Park to Baltimore. I rarely make the trip. And when I do, Bob Embry and the Able Foundation is often the reason for that. It gave me the chance to study the possibility of heroin maintenance in Baltimore some years ago. Beth and I agreed that I would cover not merely drug policy changes in 20 minutes, but I would also talk about changes in the American drug problem. I will say nothing about Maryland because this room is full of Maryland experts and that's what we're going to be talking about. This will be primarily national data. And I hardly need say that from about 1980 to 2010, we had a policy which was properly characterized by the term war on drugs. The term faded in the last decade of that, but the policy hardly changed. And you can see this reflected in the rising number of people incarcerated for drug offenses, peaked in 2007. I'll talk about the nature of the decline. It's largely reflected legislative and judicial, first of all, legislative changes that increase the severity of sentences and mandatory minimums and guidelines that led to increasingly long sentences. Treatment funding was limited and quite restricted in terms of the kinds of programs that were available. For example, the Defense Department in its funding of health services for not veterans but for enrolled persons, military and their families, refused to provide opiate substitution treatment. And of course, there was long congressional resistance to needle exchange programs, to federal funding of needle exchange programs. The only sign that there was any change in American attitudes towards drug policy was the increasingly, the decreasingly restrictive laws with respect to marijuana, in particular medical marijuana, which was often really just a way of providing marijuana to very dedicated users. But I would argue that in general, marijuana is its own policy domain and has moved entirely separately from policy towards every other of the illicit drugs. Just to give you a sense of how much of an increase there was in incarceration, I put up here state prisons, the upper line, and federal prison populations of drug offenders. And you see in particular the federal government's role, an increase of fourfold over a less than 20-year period. What's interesting is that with all that rising incarceration, which clearly was intended to make drugs more expensive and less available, what we saw over that period was a continuing decline in drug enforcement. Continuing decline in the prices of both heroin and cocaine. Marijuana and methamphetamine is a more complicated story, but these were, I think, the two drugs most harmful to society. And this consistent decline is frankly very hard to explain, but it certainly contradicts the notion that tougher enforcement would make these drugs less available. I'll skip that. Since 2010, federal policies have clearly changed in a way that I think was quite unpredictable. Certainly unforeseen. The Affordable Care Act swept up amongst the many changes the issue of making addiction treatment available to a large population. You don't yet see in the treatment episode data set a large increase in treatment utilization. But there is the promise in the Affordable Care Act through its coverage of addiction treatment, for the first time, access to treatment for a very large proportion of the heroin and cocaine addicted population. From my point of view, and most of my work deals with drug markets and drug enforcement, what's also thrilling is that over the last 2 years, former Attorney General Eric Holder and the President have for the first time spoken out about excessive incarceration and in particular singled out the lengthy sentences handed out for federal drug offenders as an important problem to be dealt with. The US, which has been sort of the hawk in international forum, for the first time is a sort of allowing for the fact that maybe nations should be allowed to experiment. And the federal government, which had previously, under President Bush, harshly attacked state innovations with respect to marijuana, is at least willing to lay down a set of guidelines under which states can allow legal marijuana. You don't see this change yet in federal drug expenditures, and I put this up really as a cautionary slide. The first 2 years are the Bush administration drug budgets, and it's not that the Obama administration is spending more money, it's just counting more categories of money as being drug-related, and it's a sort of arcane fight. What I want to point out is that over the last 4 years, even though the federal government has been making changes, you see this very slightly reflected in the drug budgets, which point to the sort of slowness with which these changes can be brought about. The states are changing much less. There has been modest reduction in drug incarcerations, but this doesn't reflect any particular attitude towards drug policy, but rather a shift in attitudes towards incarceration generally. And there have been no large-scale pardons or retroactive application of reductions, as we are about to see at the end of this week, at the federal level, when 6,000 individuals we let out after serving long sentences because the sentences are longer than would be provided under current policies. States also have not much expanded availability of treatment. They lead on marijuana policy, which is not necessarily, but has been a state policy. All states have legalization. We sort of have halfway legalization in D.C. It's interesting, there's very little support from political leaders for this. It's very much a grassroots movement. And in a number of states, lax medical marijuana laws have accomplished largely the same effect. How has the drug problem changed in this period? I want to make a number of points which I hope will be useful for you during your deliberations. One is there has been an extraordinary decline in many aspects of this nation's cocaine problem, and it's received very little attention. I'll show you a number of indicators for that. Second, which I will not talk about, is the surprising stability of marijuana prevalence. Even though it's increasingly available, there has been no large increase in the extent of marijuana use. However, the intensity of use by marijuana users is really changed to an extraordinary degree. My colleague John Calkins has done some fascinating calculations here and just mentioned one of them, a 7-fold increase in the number of daily users over a 20-year period. Prescription opioid epidemic, which has captured a lot of attention, you see in tripling in overdose deaths over the period 2000-2010, now a decline, and apparently accompanying that, a tripling of heroin deaths just in the last few years. And the question is that a result of the tightening of availability of prescription opioids? And though some of my research right now is dealing with some new psychoactive substances like spice and other synthetic cannabinoids, I'm not convinced that that is going to turn out to be a long-term problem. I think it may be, as is often the case, a blip. The market adjusts itself to this rather dangerous drug and goes back to the traditional cannabinoids. So here's one measure of sort of changing tastes in drug use, perhaps a little frivolous as a title. Look at the bottom line. This is estimates that I and a group at RAND made of drug expenditures over the period 2000 to 2010. And what you see is that cocaine expenditures fell by 50% roughly in that period. An increase in marijuana expenditures, pretty stable heroin and methamphetamine. More interesting is to look at some of the health indicators. So here we have drug overdose deaths, including prescription opioids. And what you see is that back in around 2000, there were less than half the number of motor vehicle deaths, and now they exceed that number and are continuing to rise. The composition has changed substantially. And here I've just pulled out the two most dramatic figures. The first is the number of deaths related to opioid analgesics, which you see rising very rapidly from 2000 to 2010 and then leveling out. Heroin fairly stable until about 2008 and now rising dramatically. And again, the question is, are those connected phenomena? You can see it again in treatment data. This comes again from TED's treatment episode data set. The blue line, do I have this? Anyway, the blue line declines. Cocaine accounted for over 40% of drug admissions to treatment back in 1992. Now it's less than 10%. You see the sharp rise in the number of prescription opioid admissions, and then the decline starting in 2011, and correspondingly the increase then in heroin. So again, this seems to be this relationship. But you're looking at national data that conceal huge state variation, and this is really fascinating. So on the top left, you have Kentucky, and Kentucky sort of fits the national story. Very slight heroin problem, rises a bit in 2000s, and then takes off after 2010, and prescription opioids rise dramatically over that period and then fall substantially. Fine, national story. Now look at Massachusetts. Massachusetts basically never has a prescription opioid epidemic. It rises some, but it's always a very small share of the heroin admissions. And instead, what you see is heroin taking off around 2007, and I think roughly doubling in the next 5 years. Go to California, and the story really is always dominated by methamphetamine, and prescription opioids don't make much of a dent. And heroin actually declines most of the period and just picks up at the end. And again, maybe there's a connection between prescription opioids and heroin. But sort of what I think is useful about this is just the reminder that the national story masks a great deal of state variation. So if you find that the Maryland data are very contrary to the national data, don't worry. That's a common finding. Finally, in this respect, sort of changes in the problem. Put here, I have here the emergency department visits. So 2004, they changed the system, so that's sort of when you have to start this series. And what's interesting here is that cocaine does not decline. I've shown you a number of indicators of substantial decline in cocaine. When it comes to the emergency department, you do not see that same phenomenon. And it's a reminder of the difficulty of making a consistent story out of these very different indicators. And I do not have a sort of a story that where the emergency department visits for cocaine remain so unchanged. You tell me when I have 5 minutes? Okay. So I said I would talk about changes in policy. Let me talk about some innovations. And I'll start with a sort of provocative statement that I think drug courts, which have captured so much attention, are substantially overrated. I'll give you some detail about that. I am an advocate for a, shall we say, competing innovation aimed at the same population, those that have drug users in the criminal justice system, under the supervision of the criminal justice system, and this is sort of captured under the term mandated desistance, as well known through an evaluation done in Hawaii, and I think they're substantially more promising. I think the increasing access to opiate substitution treatment, in particular making buprenorphine much more available, is one of the big changes that's important for Baltimore as well. And obviously there have been major sentencing reforms. I'm just going to talk about drug courts and mandated desistance. My objection, or my concern about drug courts is that there's all this attention to the number of drug courts, and it's now thousands, and you sort of think, thousands of courts, that must be a lot. It isn't. And I'll show you a figure in a moment. Not only do they handle a relatively small number of clients, but they're very selective about the clients they handle. On the one hand, you can say they are, in fact, directing their treatment to the treatment susceptibles. That's a very positive way of putting it. The other one is they're cherry picking. That's a very negative way of putting it, and I think it's both. So here we have some data from a study that I did with two colleagues, looking at the extent to which drug courts could contribute to reductions in the prison and jail population. It doesn't matter how that came out. Just look at the fourth line, the number admitted to drug courts. And I think this is 2008, and the number's risen some, but it's still a very small number relative to the numbers of individuals processed by courts, over half of whom have indications of a drug problem. So even if drug courts are very effective, they're going to make a very small contribution either to crime control or to reductions in prison and jail populations. Now, I think that the drug court movement could go from being a boutique if it was willing to take on more riskier clients. Whether it will work under those circumstances, I don't know. The Baltimore court is one of the drug courts that takes the most, the highest risk clients. And there's some evaluations from Australia, actually, which show that you get quite positive results with a riskier population. But the drug court movement has to take that on if it's going to be an important contribution. Mandated desistance is an idea that comes very clearly from a longtime collaborator of mine, Mark Kleiman, and it draws on sort of well-established psychological models. And if you think about the old probation, how probation and parole have worked generally, it's been, they do drug testing, and the first time the drug test comes back positive, nothing is said. About the fourth time, the probationer is told, you tested positive. About the seventh time, they're told, you're supposed to do something about it. And the 10th time, they're sent back to prison for 2 years. That's not, by anybody's standards, the right way of managing addiction problem. The idea of mandated desistance is simply you do regular testing and have small, modest, graduated sanctions. And then the question is, well, does this work? And what I'm going to show are some results from an evaluation of the Hawaii experiment, which is, they have now 7-year follow-up data, but they haven't been released, but I'm told they are equally positive. And what you see here is the follow-up. Just look at the 6-month follow-up. This is, actually now I've got to look. Missed appointments, right. And what you see is that, and that's sort of a useful indicator of compliance, what you see is that the experimental group is much more compliant than the control group. And indeed, they're very compliant. I mean, over the period of the 12 months that it was operating, most of them missed either no appointments or just one appointment. It was rare. And if you see in terms of recidivism and other measures, they're very consistent with this. So The federal government is starting to support mandated assistance experiments, and I hope to see more evaluation shortly. So let me finish by saying, even though the president hardly ever talks about drug policy, I mean, he went just last week to West Virginia, and that may be his first visit to a, sort of where the focus was on drugs. Nonetheless, there have been major changes. Unfortunately, you've got to remember, they can be reversed. Very little of this is legislative. The Affordable Care Act is perhaps now irreversible. Everything else could well be reversed. The prescription opioid problem may have subsided somewhat, but it still remains the major cause of drug-related deaths, and it's very unclear that we have any idea how to manage that. Tighter regulation may reduce that, but Mexican production of heroin has been very high in the last few years and could well be make up the market difference. Attitudes have changed. There's less support for toughness, but it would not take much of a drug epidemic, I think, to change that attitude. And my final provocative comment is I have said nothing about prevention, but I still think prevention is largely of rhetorical rather than programmatic significance. I believe the good behavior game is a great idea and something could be built around that, but what we have as prevention in this country, I think, is not very helpful. Thank you very much.
Thank you so much, Peter. That was a great overview and a good introduction to our other speakers, and I think to the day more broadly. I should say we've reserved some time for questions for the panel at the end of all four of these brief presentations. So now let's move to my colleague Marcus Backhuber. He's an assistant professor of medicine at the Montefiore Medical Center and the Albert Einstein College of Medicine, and he's going to talk to us about addiction and addiction treatment, separating myths from reality.
Thank you. Just load up the presentation here. Okay. Good morning, everyone. So thank you for the opportunity to be here today. It's really an honor to be speaking to such an incredible group of people. So I'm a primary care doctor, and I do research around addiction and addiction treatment, but mostly from a primary care perspective. And I thought it'd be useful to take a few minutes to talk about some common myths and misconceptions around addiction. A lot of this won't be news to anyone in the room here, but I think it's useful to review how many people out in the world view these issues so we can keep that in the back of our minds as we move forward today. So as far as an overview, we know that substance use disorders are common. And by way of terminology, the term substance use disorder is a medical diagnostic term that encompasses what we used to know as substance abuse and substance dependence. And addiction is a more colloquial term that's commonly understood to mean substance use disorders on the severe end of the spectrum. So between 5 and 7 million US adults have severe drug use disorders. And we know that drug overdose is the leading cause of death from injury in the US. However, despite the scope and magnitude of the problem, misconceptions about drug use and the nature of addiction are really incredibly common. So I'm going to talk about 3 specific myths and then review what we actually know about each one of them. So the first one is that addiction is a social, moral, or behavioral problem. So addiction is linked with many social problems. The hallmark of addiction really is drug use despite consequences to self or family or job or involvement in the criminal justice system. But it often gets lumped in with those as a social problem. But beyond that, few medical schools provide education on addiction treatment, so healthcare providers don't often have the skills to diagnose and treat addiction. And even further, most physicians and nurses don't think that there's any effective intervention for addiction, so they don't even view it as a healthcare or a medical problem. But this really stands in contrast to a lot of what we know from the research around substance use disorders. So in a seminal article from about 15 years ago, the authors reviewed what was known about substance use disorders and compared it to general medical conditions like asthma, diabetes, and high blood pressure. And they found common threads throughout. So all share a component of genetic heritability, meaning that a family history of addiction predisposes an individual to developing addiction. There are easy-to-use, reliable, and valid methods to diagnose each type of illness. And as everyone in the room here knows, there are effective treatments for addiction, and the response to treatment for substance use disorders really is similar as the response to treatment for general medical conditions like high blood pressure and diabetes. One example from my own work is adherence to treatment. So in a study, we looked at a group of people in maintenance treatment for opioid use disorder. So these are people who were taking a medication every day. And at about 3 months, we found 77% were still in treatment. They were still coming to the doctor regularly. And at 6 months, this was about 64%. And we looked to see what numbers were for other medical conditions, and we found these numbers were almost identical to adherence to medical treatment after a heart attack, so really no difference there. So in summary, the available evidence suggests that addiction is a chronic medical illness with periods of relapse and remission, also called recovery. And it's an important point to make because how you view the issue really shapes what you view a solution might be. So if you view addiction as a social problem, you may be more likely to favor a law enforcement approach because that's how we often address social problems in this country. But if you view addiction as a medical problem, then you're more likely to view diagnosis and treatment as an effective solution. So for our second myth is that medication-assisted treatments replace one addiction for another. So when I talk about medication-assisted treatments, I mean the use of pharmacological medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. And this is the definition from the National Institute on Drug Abuse. These are most commonly used for opioid use disorder. So this is addiction to heroin, prescription painkillers are commonly called narcotics. We can divide these into agonists and antagonists. And the agonists, like methadone and buprenorphine, activate the same receptors in the brain and body that heroin does, but they're administered in a controlled medical way. And the antagonists block those receptors so that if a person uses, they don't experience the high. So what we now know is methadone treatment. I'm going to focus on methadone treatment because it tends to be the most controversial. What we now know as methadone treatment was first described 50 years ago this year in a paper by Drs. Dole and Niswander at Rockefeller University in New York City. And they were drawn to using methadone to treat heroin addiction because of their experiences that people with heroin addiction were extremely unlikely to achieve long-term recovery with behavioral therapies alone, with counseling and psychotherapy. So they came to view heroin addiction as what they called a metabolic problem or a medical problem that required a medical treatment. So in this study, they took 22 patients and gave them methadone in combination with psychosocial services and psychosocial support. And they write that with this medication and a comprehensive program of rehabilitation, patients have shown marked improvement. They've returned to school, obtained jobs, and have become reconciled with their families. So they found very positive outcomes. Since that time, methadone treatment has really been established as a standard of care. Research has consistently shown that methadone treatment reduces drug use, relapse, overdose, and death, reduces HIV and hepatitis C infection, and increases employment and reduces criminal activity. But one of the major critiques of methadone is that people taking it are physically dependent. They develop a physical dependence to methadone. But the fact is that every human being taking opioids, including methadone or buprenorphine, for a prolonged time period develops a physical dependence. And this is not the same as an addiction. In fact, way more often than not, people in methadone treatment are doing much better in their life relative to when their addiction was untreated. So the reality is that medication-assisted treatment is the most effective form of addiction treatment. So for our last myth I'd like to talk about is harm reduction encourages people to use drugs. So when we talk about harm reduction interventions, we're talking about interventions that seek to minimize the harmful effects of drugs rather than focusing on abstinence alone. And these interventions are oriented towards improving quality of life and delivered in a non-judgmental way. Most importantly, I think, is that these interventions recognize that there's a continuum of drug use from abstinence on one side to heavy, risky use on the other side. And interventions seek to move people or empower them to move themselves from the less safe end of the continuum to the more safe end of the continuum, sometimes in baby steps. So for an example, syringe exchange programs, we know from research, much of it here from Hopkins, that people participating in syringe exchange have about a 50 to 80% decrease in sharing needles, with a corresponding decrease in HIV transmission and hepatitis C rates, and no corresponding increase in drug use. And a more recent example is naloxone distribution to prevent opioid overdose mortality. So naloxone is an opioid antagonist or blocker that rapidly reverses an overdose. Research has shown that friends and family members of people who use drugs can be trained to accurately identify an overdose and administer naloxone, potentially saving a life. And since the late 90s, over 150,000 vials of naloxone have been distributed, with 26,000 overdose reversals. And the research has consistently not found an increase in drug use. The worry was that people would increase their use because they had naloxone as a quote-unquote fail-safe, but that hasn't been evident. So in summary, as everyone in this room knows, drug use is a fact of life, and research hasn't found evidence that harm reduction interventions increase drug use. So the reality is that reducing the harms of drug use is critical for personal and for public health. Just to summarize the major points, so the available evidence indicates that substance use disorders are chronic medical illnesses, medication-assisted treatments are the most effective therapy, and harm reduction interventions can provide important benefits without increasing drug use. Thank you for your time.
Thank you, Marcus. So now I am very pleased to introduce, I apologize for my multitasking here, Daniel Webster, who is a professor here in the Bloomberg School and the director of the Center for Gun Policy and Research. And he is going to present some hot off the press, brand new results from a study that we are doing looking at how law enforcement practices around illegal drugs in Baltimore influence violence.
Thank you, Beth. And also thank you for taking care of my slides and multitasking so well. I've spent 24, 25 years now looking at a variety of strategies to reduce gun violence, legislation, litigation, policing interventions, community and behavioral interventions. And being in a city like Baltimore, it's sort of astonishing now in hindsight that it took me so long to start to look at the drug part of this equation. So it was only very recently, and with the kind support from the Able Foundation, that we've started a study where we're looking at over time in Baltimore various ways to look at drug law enforcement metrics and how those are or are not correlated with subsequent changes in gun violence. So I'm just going to say a few brief things about policing as it relates to illegal drugs and violence, and Major Franklin will cover that probably quite well in his talk. But the goal is reduce sales, disorder, and all the problems connected to it by heavy policing, and in essence cause a great cost to those who are using and selling drugs. There are a variety of approaches. If you've watched The Wire, you've probably seen a lot of those, or in other shows. Drug raids, buy and bust on the street, those kind of more classic things I think people are more familiar with. There are other strategies that police have used that are more comprehensive in looking at a variety of related problems in that community that might be contributing to the drug problem. And it goes without saying that and it's frustrating to me that we don't have hard numbers on this, and maybe Peter knows where I can get them, but we invest an enormous amount in local and state law enforcement efforts on combating illegal drugs. It's easier to track that at the federal level, but digging into what are places like Baltimore City spending on this and the state of Maryland, it's a little more elusive. We went into the study reviewing the research, and I was actually shocked at how few studies there are, at least few good studies, that actually examine this problem, given the enormous investment that we place in this. So one study that reviewed data through 2010 looked at 11 studies where they were looking at change over time. And in 10 of those 11, the response to very traditional taking down drug organizations type of approaches actually elevated violence rather than decreased it. Another review that looked at more problem-oriented, community-focused, more comprehensive kind of strategies to address this found, in some cases, some changes in drug violations, but none of those studies found any association with violent crime for the policing activities that they were undertaking. Some may be familiar with a very popular approach now called focused deterrence, popularized by David Kennedy. Briefly, this involves looking at a high-risk group of individuals, calling them in, directly communicating that they're going to be the focus of the law enforcement attention, and in essence, get your act together. We're going to provide you some social services, and the community is also going to have a voice in basically saying, we need you to stop this. That's sort of it in a nutshell. But if you don't follow their advice with their deterrent message, the very heavy law enforcement response. I'm not going to go into all of those right now because I want to focus the limited time on the data. But this approach is a little more encouraging, particularly when it looks very specifically at gang and gun violence as what the focus is, what the message is. And in most of these cases, they got very favorable responses, substantial reductions in gun violence. Part of their message actually was, we're not going to arrest you for selling drugs. We're going to arrest you for shooting people. If you did shoot people, we will arrest you for drugs. So that was part of the message. But in the very few number of interventions where law enforcement went in directly and the message was stop selling drugs, generally overall found no response in terms of reductions in violent crime. The best case scenario that David Kennedy talks about a lot was in High Point, North Carolina. The best study that looked at this found a 12% reduction in violent crime. I consider that sort of a best case scenario. So what's Baltimore been doing? I was here as a doctoral student. I remember very well Mayor Schmoke and coming to the school and talking about this problem in new ways. And frankly, it was that era when crack cocaine was devastating so many of Baltimore's communities that I decided to do this. And but the common wisdom with law enforcement is we're gonna do this with policing drugs. That's how we're gonna bring down our drug rate. So I'll briefly share what we've done. We collected, we have arrest data for drug-related offenses. We're looking at outcomes, non-fatal shootings, and homicides as our key outcomes of interest. In addition to just looking at the arrest data, we also wanted to look for the most potentially disruptive kinds of law enforcement actions where they're generally trying to take out a whole group. And the way we identified them is through meticulous search from the Baltimore Sun. Through any stage of arrest, indictment, or into the courts. And we defined a major drug bust by having 5 or more suspects or certain very specific charges that suggest conspiracy or group-related activities or other federal-related charges. This is our graph of how the number of major drug busts have changed over time period that we're studying, to 2003 up to right now, and you see a noteworthy decline. You also see the same general pattern if just overall drug arrest. Here's the most important piece of data that I want to convey. We had to really struggle to figure out if we're going to measure the effect of these major drug busts, we have to make some assumptions about where those effects are going to be and when they're going to be felt. And we didn't have a lot to go on other than sort of focus groups and talking to people about, okay, how do things respond when a whole unit is taken out of their business? So we looked at models where we assumed the effect would be only for a month, 2 months, 3 months, 4 months, 5 months, 6 months, and then we went to 9 and 12 months. Basically, the only thing that we found is that during that very initial first month, a 64% increase in gun violence associated with that major drug bust, presumably a disruption in that market that was causing competition, and competition in the drug market often means people get shot. After that, we generally found no statistically significant effects after that initial shock into the system. When we widen the lens a little bit, these are police post-level analysis. When we widen the lens to think about the effects potentially being in broader whole police districts, we see some evidence of elevated violence going into 3 to 4 months. But generally, most of the action is right here. Other noteworthy things from these analyses is that when you the number of arrests that you do this month is not going to have any relationship to how many people get shot the next month in an area that you're policing. That's what we find when we look at our data. The same is true for weapon offenses. The ceasefire program, that's the focused deterrence model, we see some evidence of protective effect, but not quite statistically significant. The only thing actually that Baltimore was doing that we had very clear and statistically significant protective effects against people getting shot was the implementation of safe streets in an area. There were some other short-term effects from special units focused on what Fred Bielefeld just called bad guys with guns, also had some protective effects. Those, the ranks of that group were greatly curtailed, and their effects faded with that. I think I'm probably, this is just, I wanted to, we're going to dig some more into these data. I'm very curious, are there certain set of circumstances that are more likely to generate this post-bust violence or even have a protective effect in some cases? So we're drilling down into this more so that we have a better sense. What I'm showing you is average effects. Average out, mostly nothing going on, even despite our great investment in this as an approach to reduce gun violence. But we're going to see if we find some rays of hope somewhere in the data points. All right, I think I'm going to end there. Future work, sorry. We are going to get some additional data from HIDA to look at this. Again, they have very detailed data that I think will be useful for us, including some of the differences in the groups that were being targeted. All right?
Thank you so much, Danielle. So now moving to our final panel speaker. And I want to thank the panelists for adhering to my strictly imposed time guidelines, because despite starting 15 minutes late, we're actually right on time. So our final speaker, who is a great follow-up to Dr. Webster, is Neill Franklin, who has on-the-ground experience in law enforcement in Baltimore and is currently the Executive Director of Law Enforcement Against Prohibition.
Well, thank you. It's a pleasure to be here. And I'll begin with all the things that Dan said, and as he made reference to The Wire and those investigations and clearing corners and working undercover, been there, done that. So thanks, Dan, for covering that for me. Makes my job a lot easier here since we have time restrictions. I already took 40 slides out of my presentation so that I can stay on track here, and we'll see how that goes. But I can't promise you anything. LEAP, Law Enforcement Against Prohibition, 13-year-old organization, international now, of criminal justice professionals, cops, criminal prosecutors, judges, and beyond, who have spent a lot of their careers on the front lines of the war on drugs, doing those very same things that Dan referred to. And it's been a complete disaster. That's one thing that we realize. It's crystal clear for us. Personally, 34 years in law enforcement here in the state of Maryland, and I've seen it firsthand. It doesn't work. We have some of those members of our organization here with us today. We have Lee Maddox, we have Eric Sterling, and take time out to chat with them if you can. We have Bill Freed in the back. We have Amos Irwin sitting here. Great information, great people to talk to. But I'm going to take a quick page out of a book from someone else, Jan Hubolt, who was my sensei in the Baltimore Leadership Program. And he told me to give people vision. Generally, during a presentation like this, I tend to talk about the problems of drug prohibition policy and where we are. So I'm going to take it in somewhat of a different direction this time. Referring to part of the title from this talk of mine, post-drug war policing. Post-drug war policing. So what would it look like if we made this hurdle and head in the right direction? And Michael described earlier the goal of the meeting as we know, but the ultimate goal is really to turn this public health problem that we're dealing with over to public health practitioners and get it out of the hands of the police and criminal justice. And that's my ultimate goal and the goal of our organization. We've been attempting to solve a public health condition with criminal justice solutions for far too long, and it doesn't work, and it's time that we turn that corner. LEAP is also a member of law enforcement. You may have heard this. We announced this group last week, law enforcement leaders to reduce crime and incarceration at the same time. Criminal justice professionals, chiefs of police from all across the country, from Charlie Beck out west in LA, Bratton, Gary McCarthy up north in Chicago, even our commissioner here, Kevin Davis, and Kathy Lanier in Washington, D.C. And we, LEAP, are going to do our best to continue to help guide that group in the right direction of what I was referring to. So let's get moving real quick. For those of you who refuse to go see your optometrist, I'm going to help you with this and read a little bit of it. And I'm one of those people, I need new glasses now, but I do my best. Stringent laws, vigorous prosecution, and imprisonment of addicts and peddlers have proved not only useless and enormously expensive as means of correcting this evil, but they are also unjustifiably and unbelievably cruel in their application to the unfortunate drug victims. Repression has driven this vice underground and produced the narcotic smugglers and supply agents who have grown wealthy out of this evil practice and who, by devious methods, have stimulated traffic in drugs. Finally, and not the least of the evils associated with repression, the helpless addict has been forced to resort to crime in order to get money for the drug which is absolutely indispensable for a comfortable existence. Does anyone recognize that? I know some of you do. Don't say anything, Lee. Does that sound like something a cop would say? August Vollmer is not just any cop, or wasn't just any cop. Going back to the 1920s, this is what he said in the 1920s when we started down this road of repression for these drugs that are currently illicit today. He was the chief of Berkeley City Police Department. He then went on to be one of the heads, the leaders of the International Association of Chiefs of Police. Imagine that. The president just spoke to that group of law enforcement leaders just a couple of days ago about this problem of reducing crime and incarceration at the same time. And the fact that we just have too many people currently in prison, and that's why we now have this wonderful bipartisan effort to change this. So that's who that person was. We should have listened. Law enforcement should have listened. Law enforcement isn't totally deaf on this issue. We just have selective listening. Now, we've already seen some figures. This is the only chart you're going to see in my presentation because I knew that the presenters before me would cover a lot of great data, which they did. But this only refers to arrest, not people being in prison, because arrest is important. Just the arrest alone is going to drive someone into a downward spiral. You don't have to do time in prison. This will prevent you from getting a job. This will prevent you from doing so many other things. And the arrest alone, especially since most of those people are poor anyway, just drives you into economic depression. From 1970 to 2006, you can see this. The darker color is adults and the rise in arrest in millions in this country. The yellow is total, and purple, I guess I'll call it, is juveniles. And that's from 1970 to 2006. And total arrest during that time, we ended up with 43 million. And this is what has led, and these are nonviolent drug arrests, folks. These are nonviolent drug arrests. And this is what has led to our 3.3 million people that we have incarcerated today, by far. There's no question about that. And it's not cheap. It's not cheap. It's cost us around $1.3 trillion thus far. The president and others have referred to current incarceration is costing us about $80 billion a year in this country. Jeffrey Myron, economist from Harvard University back in 2010, and he's done some other things since then. Back then, he said on the low end, cops, courtrooms, and prisons for enforcing these drug laws, $50 billion a year. $50 billion a year. We cannot afford to continue in this direction. Here's another smart person. Anyone recognize that guy? He got it. Robert Peel. You know who Robert Peel is? Sir Robert Peel began modern policing. That's what we say. He began modern policing in 1829, established in London. That's why they call him Bobbies over there, for his name, Robert. And he had a group of commissioners who put together some basic policing principles that we follow even today. Bratton out of New York refers to him all the time when he gives speeches. And there's 9 of them, but I'm only going to cover a couple of them because of time. And these principles are extremely important, as you will see. Number 1 is to prevent crime and disorder as an alternative to their repression by military force and severity of legal punishment. Military force. It's kind of like where we've been heading today with law enforcement, isn't it? And it's not because of the war on terror, folks. We began this back in the late 70s and early 80s with the war on drugs. Number 2, to recognize always that the power of the police to fulfill their functions and duties is dependent upon public approval of their existence, actions, and behavior, and on their ability to secure and maintain public respect. See, it's not what we in law enforcement approve of, it's what you approve of. Police departments and police agencies should be governed by the people. They should be responsible to the people. They should answer to the people. So when the people finally get to this place of saying we no longer want these laws that we are currently using to manage drugs in our communities, you know what? When the polls indicate certain things, then we in law enforcement need to abide by that. But we're of the executive branch, so we listen to our policymakers, unfortunately. Just got to get our policymakers in line, like we did with Dan, by the way. Just kidding. I'm going to bypass number 3 and number 4 for the sake of time and move forward to number 5. To seek and preserve public favor, not by pandering to public opinion, but by constantly demonstrating absolute impartial service to law, to complete independence of policy, and without regard to the justice or injustice of the substance of individual laws, by ready offering of individual service and friendship to all members of the public, without regard to their wealth or social standing, by ready exercise of courtesy and friendly good humor. Know any funny cops? If you don't, that's a problem. Friendly good humor, and by ready offering of individual sacrifice in protecting and preserving life. Yes, we want to go home at the end of the day, But we have a service, we have a duty to you first, to the public first. If we can't honor that duty, if we can't do that, then go do something else. Go get another job if you can't make that commitment. And I'm going to wrap it up. Skipping 6, on right to 7, which is one of the most important. To maintain at all times a relationship with the public that gives, excuse me, reality to the historic tradition that the police are the public and that the public are the police. The police being only members of the public who are paid to give full-time attention to duties which are incumbent upon every citizen in interest of community welfare and existence. See, it's public safety is a community responsibility first and foremost, and the police are part of that community, or they should be. We just get paid to do it 24/7. And these drug laws are partly responsible, greatly responsible, for the collapse of this principle. And number 9, to recognize always that the test of police efficiency is the absence of crime and disorder and not the visible evidence of police action in dealing with them. Now, as I wrap it up, just remember that the absence of crime. And from warrior to guardian is where we need to go. And just these quick points here. The war on drugs has clearly become a war on people. You can't have a war on drugs. It's like me having a war on this podium here. It doesn't do anything until I do something with it. Now, if I break it into pieces and start whacking people over the head with pieces of wood, then you might want to prohibit podiums. But it's the environment in which it exists. And we have created a very dangerous environment for managing drugs in our communities. We must focus on the people, not the drugs. And that's what this is about. Make health a priority, not drugs. Lead with health practitioners, not the police. Education, treatment, compassion. Change laws, decriminalization, legalization, regulation, and control of drugs. Just think of Portugal, where for about 13 years, they've moved to a place of decriminalization. And what has happened now that they're focusing on people instead of the drugs? 71% reduction in cases of HIV for intravenous drug users. That's new cases. 52% reduction in overdose death rate. Imagine if we had that. Imagine if we had that here in the United States from us changing our policy, something that we're going to work on. You know how many lives that is? 25% reduction in overall drug use by 13 to 15-year-olds. That's important to us. I think that's important to most of us. And a 22% reduction in overall drug use by 16 to 19-year-olds. Yes, for the adult population, we are experiencing more people coming in for treatment. That doesn't mean that drug use has gone up, but now that they've removed the stigma, people feel comfortable with coming forward. So, what are we going to do, folks? Dan said that this is where we get down to the details for making this a reality, right here in this room today. They say that the devil is in the details, not that I'm looking for the devil. But that's what we have to do today as we break into our group. So let's go to work. Thank you.
Thank you, Major Franklin, and thank you to all of our panel. Could we bring the panel back up and open it up to questions?